Thank you for the great lecture. Thank you for your great lectures. I'm very much impressed. So this is all up to date. We have included the latest paper and the latest idea on the pathophysiology, imaging and treatment. So very fine event. Thank you. Now I changed my title a little bit to give you a little bit broader scope on the examination of the vestibular and the oculomotor system. And the basic question I'm going to focus on is which examinations do you really need? What is the contribution of these laboratory tests to your concrete diagnosis in each individual patient? When you have a look at the examinations which are done in patients, this is from 100 consecutive individuals who came to our center, one can realize that too many laboratory examinations are performed which do not contribute to the diagnosis. For instance, an MRI espinal is not indicated. There's nothing like cerviogenic vertigo. And the consensus conference of the German ENT and neurologists agreed no MRI of the spinal cord in vertigo and dizziness. What you see here, many patients receive a long-term blood pressure measurement which does not contribute. Doppler and duplex examinations also not. EEG is not indicated. Echocardiogramma is rarely indicated. So a lot of examinations are done which lead to a waste of time, which distract, and which makes the patients longer sick than necessary. Here in dark gray, you see what really helps. This is a neuro-ophthalmological examination, video oculography, head impulse test, calorics, rarely an MRI cranial. And if you focus on these few examinations, you will speed up the diagnostic process. Here you see it in red, the audiogramma, and this is, as I demonstrated before, an essential part for the diagnosis of enfermedad de Meniere. So this has to be done, and it's explicitly stated that this is associated con un ataque de vertigo, and not a hearing loss in 2003, and now an attack of vertigo. So this should go hand in hand to support the diagnosis. And here you see an overview of potential laboratory examinations which can be applied. So for the Sistema oculomotor, we have the video oculografia, which is very helpful. Fotografia del fundus, it's not that relevant. It's part of the ocular tilt reaction. Sistema vestibular, pruebas calóricas, vHIT, very important. Visual vertical subjectiva, very important and easy to perform. And potencial evocado myogenico vestibular cervical, the ocular, you will see. Posterografia, rarely. An analysis within a network will allow you to identify certain patterns specific for certain diseases. So functional dizziness, we have a specific pattern. We have orthostatic tremor, specific pattern with a frequency between 14 and 16 Hertz. For ataxia cerebellosa, we can have a 3 Hertz sway, but otherwise it's not very helpful. For you as clinicians, if you do not have a posterographia, you don't need to invest in it. And analysis de la marcha is also not that relevant. So now let's begin with the video oculographia. So by video oculographia, you can quantify the different types of eye movements, in particular saccades e segmento suave, whether this is saccadic or smooth. And these are the major indications for video oculography. And here you see how it is performed. It's a simple technology which has been modified over the last 20 years. So here you see the camera, which identifies the pupil. The patient is sitting in front of a screen, and then you get quantitative data, for instance here of saccada. If a patient performs a saccada, you can particularly measure the peak velocity. This is one of the most important parameters. Of course, you can measure the target, the amplitude of the saccade, and show whether saccade is hypo or hypermetric. And here's one disease where it makes sense to apply a quantitative measurement. Look at this person. She's performing saccadas vertical. What's wrong with the examination? What should have the doctor or the patient been done? I took it with my smartphone. Lift the upper eyelids. Here he attended the last meeting, and some attended a meeting last night on this disease. Because it's really illuminating if you look what is happening with the upper eyelids lifted. Then you can identify the severe impairment of saccadas vertical. What is the diagnosis? Quale diagnostico correcto in this patient? It's an inherited lysosomal storage disease, which typically leads to a saccade palsy, and in most patients, smooth pursuit is normal, so they have no gaze palsy. So there's a distinct lesion in the rostral interstitial MLF, whereas the nucleus interstitialis Raymond-Carral is intact. So this is typical of Niemann-Pick type C with a supranuclear vertical saccade palsy. And this is due to a dysfunction of the RIMLF, where the burst neurons for vertical saccades are located. Here you see another paciente. She should perform vertical saccades. If you see that in a patient, and your colleague mentioned that in the context of ataxias, this is Niemann-Pick type C, which is treatable with microstat, and another drug I'm going to present at the very lecture of this day's event. So, and in these patients, you really can quantify the saccades. Here you see a healthy control, and there you see patients with different types of an impairment of saccades. Here you see a healthy control and 5 different patients. So here, this was moderately impaired, and then the impairment is worse and worse and worse. And here you see a patient who is blinking during saccade to overcome the saccade palsy. And here you see another patient. His vertical saccades are very slow, but the saccadas horizontale are still good. And we quantified that in a huge cohort of patients with Niemann-Pick type C. So it's an ultra-rare disease, 1 in 100,000. And we have a cohort of 55 patients in a multinational cross-sectional study. Here in red, the velocity of healthy subjects for vertical and horizontal saccades. And you see here for vertical saccades in 54 out of 55 patients, that means in almost 100%, you see this clinical hallmark. So, supranuclear vertical saccade palsy is a very early marker of the disease, and therefore it makes sense to evaluate vertical saccades. In contrast to what was reported in many papers before, there's no difference between upward and downward saccades, and only 50% have a vertical gaze palsy. That means it's essential that you specifically examine the vertical saccadas. Later we have time for a hands-on course, and we can work with that. Now we move over to function, dysfunction, and testing of the vestibular system, tres canales semicirculares, and organos otolíticos. What is normally presented in many lectures is a pathological head impulse test, but this does not reflect clinical reality. Which side is not working properly? Left or right? The left one. Okay. But then you have a lot of patients where the results are very ambiguous and you don't know whether it's pathological or not. These patients are rarely shown during presentations, but they reflect clinical reality. I showed this slide before. We did this study in 500 patients, 3 examiners, all experienced, including myself, and the sensitivity was only 66%. So only very reduced VOR gains below 0.4 could be detected with a reasonable sensibility. So the simple statement is you need a video HIT. There are several systems on the market. One is from Autometrics and the other one is from Interacoustics. They give identical results, so we have compared them directly in 550 subjects, patients and healthy subjects. The advantage of the video head impulse test from Interacoustics is that you have a camera either on the left or on the right eye, so you can switch the eye. If a patient has a abducent palsy or is blind on one eye, then you can examine the other eye. But otherwise, both systems are identical. But they measure the VOR gain in a different way. I'll explain that later. Here you see Professor Erich Schneider. He's the engineer, electronical engineer by the way, who had developed this system. And as I said before, it measures the angular eye velocity by having a look at the pupil. And here are inertial sensors which measure the angular head velocity. And Erich Schneider had a VOR deficit without knowing it. I'll show you later the original recordings. So even if you do the head impulse test with a very high angular velocity, you will not identify it because he made a refixation saccade during the head impulse test. These are called covert saccades. On the other side, everything was fine. The nice thing with these systems is they evaluate the quality of your head impulse test. And they use for the calculation only adequate hits. Otherwise you get a standard deviation which is too high. Here you see a comparison of the prueba de impulso cefálico with various systems. So in the past, the gold standard was a semi-invasive technology, the surge coil technique. So patients had contact lenses with wires on their eyes. They were sitting in a magnetic cage field, and the changes of the magnetic field were measured. This is still the gold standard for animal studies, for instance. And if you compare that with the video oculography, a non-invasive technology, you will get the same results. Question for you. Does the video head impulse test or the head impulse test examine only one labyrinth or both labyrinths? Both. Because you get an inhibition which is 20% from the other side. So that's the advantage of the caloric irrigation, which allows you to specifically examine only one labyrinth, but only the horizontal canal, more or less. But you have always to keep in mind that you also measure the other side. So if you have a vestibulopathia aguda unilateral, that will never go down to 0 because you have 20% from the other side. And this is the reason why for vestibulopathia aguda unilateral, the gain which we're discussing is 0.7, and for vestibulopathia bilateral, 0.6. This explains the difference. So each of these technology has its pros and cons. Here you see a normal head impulse test. Here the scale from 0 to 300 milliseconds. What is shown here on the ordinate is the angular velocity of, in red, the head, and in blue, the eye, and normally it's equal. And the interacoustic system uses the peak velocity at 40, 60, and 80 milliseconds to measure the gain of the VOR. The autometric system uses the area under curve, but the results are identical. Oh, each technology has its pros and cons. So normally we use the 60 millisecond here value, and you should reach an angular velocity of about 200 degrees per second. for an adequate measurement. If you go too far, the gain will go down because you run into saturation. If you just do slow angular velocities, you do not properly measure the high frequency, but only the middle frequency VOR. I'll later show at the end of my presentation the results of a worldwide survey, which I mentioned before, showing a large variability what is normal and not normal. So some data are in the literature, also here for children. So here the middle value was 0.97 plus minus standard deviation. In other big studies it was 1.06, and we normally use 3 standard deviation to define a normal range. So here in this lab, everything below 0.85 was considered pathological. Good. Another thing which I realized, this is something which you realize when you do the examinations on your own. So I always do the video head and pulse test on my own with my patients. And I realized if the camera is in front of the right eye, it's different than if the camera is in front of the left eye when you perform the head and pulse test. And this we systematically examined in 100 healthy systems, healthy individuals, using the Autometrics and the interacoustic system. And if the camera is in front of the right eye and you turn the head to the right, there's a 5% bias towards the VOR to the right. We don't know why. Every explanation which you consider would predict exactly the opposite. So we have no explanation for that. We were considering that different weight and things like that, adduction, abduction, things like that. It turned out not to be true. So, but you have to consider that if the camera is in front of the right eye, the VOR to the right will always be a little bit higher than to the left. And this is independent of the system. It's 5%, which is quite remarkable. Another thing for your clinical practice, I don't know who has already put the camera in front of the face. It's not the most convenient device. So I have always problems here, top of the eyes. Others have problems here on the nose. So if you put an adhesive on top of the nose, you can fix everything much tighter. And the compliance of the patient will be better and the artifacts will be lower. Here you see the recording from Erich Schneider. And as I pointed out before, he's doing a refixation saccade during the head turn. This is a covert saccade, and the head and pulse test looks totally normal, although his VOR gain is only 50%. The other thing is, if you measure in this patient here the area under curve, you may get a normal value. Did you realize that? Because here you get a gain of 1.45 at 80 milliseconds. There's an overshoot. Yeah? So each system has its pros and cons. But for you it's very important to have a look at the raw data. The raw data is extremely important. And the other thing is, you should have a look at the standard deviation. And this should be normally below 10%. Here you see the standard deviation. Then the quality of your measurements is fine. Here's 15%, and there's 2%. So standard deviation, raw data, that's good. And best you do it on your own. You don't need a technician for that. Okay, here you see a patient with an extreme vestibulopathia bilateral, and of course saccades overt, which occur here 200 milliseconds after that. Then we will examine patients with cerebellar ataxia. And you get patients with cerebellar ataxia, they have a refixation saccade, although their gain is normal. And this leads to false pathological findings. You think they have a VOR deficit, but in fact they don't. Clearly here the refixation saccades after 200 milliseconds, clinical examination said, okay, it's clearly pathological, but the gain was still within the normal range. And therefore, quantification is essential. Good. Now, any questions related to the video measurement from your side?
Vertical canal?
not necessary. It's a waste of time. We don't have good normative data, and I don't like people who promote the vertical canals. It's really a waste of time. That was a nice event at the last Barani meeting in Lund in Sweden. Experts on the vHIT. And they showed the recording, and the gain was 1.45, yeah, for a vertical canal. And these were the experts, or presumed to be the experts. Yeah, this was an original recording, vertical VOR for the left anterior canal, 145%. Forget it, okay? So of course it's just confusion. The same is true with the Unterberg. Don't do it anymore, it's just confusing. And what is the background for that? In almost every disease, the horizontal canal is affected. So you don't need the vertical canals. And the recording is very difficult, calibration is difficult, and it's not that comfortable for the patient. Okay, now we move over to something which was already described by Robert Barani in 1914, and that was a major contribution to the field. And for this examination and other research he did, he got the Nobel Prize for physiology. So in those days it was a little bit easier to get this award. It's a very simple technology at first glance, but to perform it properly requires a lot of skills and experience. So you irrigate the horizontal canal if the head is in a 30 degrees upright position with 30 and 44 Celsius degree water, which leads to excitation and inhibition. And who is using the caloric irrigation? One? Okay. Caloric? Yeah. Good. Okay, here you see a video, it's very easy. So head 30 degrees upright, then the horizontal canal is earth vertical. You measure by video oculography the peak slow phase velocity, and here over time, and then you get these results. This patient has a clear deficit on one side. So, but it takes often 20 to 30 minutes, and the head impulse test takes 2 minutes. Yes, so that's a major difference. Here, the Yonkey's formula says if everything is not more different than 25%, it's assumed normal, but this was never validated. We agreed on 6 degrees for bilateral vestibulopathy. What is your concrete procedure? I would always start with a video hit. If the video hit is pathological, you have made the diagnosis. If the video hit is normal, and you have a patient with Meniere's disease, you do the calorics. And the patient with Meniere's disease need the calorics anyway. If the head impulse test is normal and you expect unilateral or bilateral deficit, then you do the calorics. Except patients pay for each examination, as they do in Germany. Then they get everything. I don't know how it is in your country. You have to have both temperatures, 30 and 44 degrees. Second, what you should not do is using air. Air isolates. Air has no good caloric capacity. So it's the worst medium. You can use a vacuum, that's worse. But air, don't use air. So companies offer you a caloric with air and water, and you should always use water. It's much more reliable. Simple physics, grammar school, physics, water, and air. Okay, so air should not be used anymore. Further questions?
Which parameter, fixation index?
Fixation index is a good thing, but it evaluates something completely different. It's similar to visual fixation suppression of the VOR. It evaluates the function of the flocculus. So you can do that during the calorics. Fixation suppression of a peripheral spontaneous nystagmus. So the signal comes from retinal slip If your cerebellum is intact, you can use the retinal slit to suppress the nystagmus. If not, you have impaired visual fixation, suppression of nystagmus. This is analogous to this test. Of normal what? Normally you suppress it by 90%. That's it. Not 100%, because it's really severe. If you have 30 degrees per second caloric nystagmus, then you cannot suppress it completely. Okay, now we can come to the utriculo e sacculo. What is the function of the utriculo e sacculo? What do they sense? Gravity and linear. Is there a difference between gravity and linear acceleration? Yes. So, we are now in Bern in Switzerland. It's the year 1906. Albert Einstein is bored sitting in his office, and then he got the idea gravity is the same as linear acceleration. One of the brightest moments in his mind, in his life, as he later stated. So gravity is also permanent acceleration, but we don't feel it. Okay, so this is what they sense, and it all depends on the head position. Yeah, the sacculus normally sense gravity, but if you turn the head by 90 degrees, it's the opposite. Okay, mareo otolitico. Do you know any otolith, mareo otolitico? When does it occur? Okay, so it's most frankly caused by the doctor. It's post-repositioning mareo otolitico due to repositioning of the otoconia to the utriculo, therefore to the utriculo. And patients have for 1 or 2 weeks this postural imbalance, and you have to tell the patient that beforehand for 2 reasons. You sound like a prophet, and you are a prophet. And secondly, otherwise patients will not be happy. So they have to interpret that in a positive way. This is a good sign. It indicates the crystals are back home. Okay? Back home, where they come from. Okay, so these technologies are known now for 20 years. Many papers have been published by various groups all over the world. As you will see later, the clinical applications are very limited. You measure by the ocular vestibular evoked myogenic potentials, mainly the function of the utriculo. The stimulation I'll show later is, for instance, by a mini shaker, and you record from the contralateral inferior oblique muscle, and the cervical vamp are an inhibitory response, and therefore there had to be some muscle tension to get this inhibitory response P13 and 23, which is ipsilateral. So this is a vestibulo-ocular reflex, and this is a vestibulo-spinal, vestibulo-colic reflex. So utriculo, ocular, sacculo, cervical. That's the way you may remember it. So here again, the utriculo, you stimulate by mini shaker. The signal goes to the contralateral inferior oblique muscle, and the patient has to look 30 degrees upright. Is anybody using the O or C vamp? No. Okay, then we can quickly go through that. You have no mini shaker? Here you see the mini shaker. Tuck, 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 tuck. And here you see the patient is looking 30 degrees upward, and you record from the inferior oblique muscle. That's the best constellation. Okay, and for the sacculo, we have an acoustic stimulation. Patient lifts the head by 30 degrees. Then you have muscle tension, and you get an ipsilateral inhibitory response. I do that in all of my patients, but mainly because they have a private health insurance. We have to survive. Okay, and then you get an ipsilateral inhibitory response, and after neurectomy, this is gone. So what are the major indications? And we have to look, a close look at the anatomia functional del nervio vestibular. We have the superior and the inferior vestibular nerve. The superior vestibular nerve mainly innervates the utricle. So if you have superior vestibular neuritis, the ovamp should be reduced or absent. But this is not always the case. If you have extremely rare inferior vestibular neuritis, the cvamp should be absent or decreased, which is even more rare. Inferior vestibular neuritis, we discussed that before. You get a nystagmus, which is the opposite as the BPPV, posterior canal. So in posterior canal BPPV you have an excitation, and there you have an inhibition. So a vertical torsional nystagmus beating in the opposite direction of your BPPV, which you know, this can be inferior vestibular neuritis. But in most patients, the inferior vestibular nerve is spared. Why?
Because it's not narrow.
Okay, so this here, the canal here is much longer and longer, and there are a lot of spiculae. So if this nerve swells, the risk is higher that it's damaged. Secondly, we had a look at herpes simplex, and there's more herpes simplex here in the upper than in the lower part. And thirdly, we have a double innervation for the posterior semicircular canal. This explains one of the most frequent complications of vestibular neuritis. What is it? Post-infectious BPPV of the posterior canal, which is preserved. Otherwise, you wouldn't get it. Yeah, that was already described in 1984. So, post-infectious BPPV. Yeah, Senor?
I'm thinking about the Dysfunction anyway, which is...
Okay, he was talking about herpes zoster, which affects the whole nerve, and that's the only exception where you can get a skew deviation in a peripheral lesion. We described the case. So if you have complete loss, you can get a transient skew deviation in patients with a peripheral lesion. Okay, I had one exceptional case, and other colleagues do have similar cases. She came with acute onset of otolith dizziness, so Mario, and she had an isolated dysfunction of the otolith organs on both sides. So the left utricle and the left saccule were impaired, but this is really exceptional with the normal canal function. Okay, here we have this Guida Practica written with the American Academy of Neurology, and the major statement is that O and cvamp are relevant for the diagnosis of syndrome de la essencia del canal superior. Here is a typical case which we published in Neurology recently, nothing particular. Here you see the amplitude of the ovamp. Right oblique means left semicircular canal. And here the amplitude is much higher than on the other side. And here you see the cvamp, so the area under curve on the left side is much higher than on the other side. And this reflects basically the autophony, autophonia. And here you see the high resolution CT scan. That was the patient I showed at the beginning with the examination of the tuning fork. Good. So to summarize this up, maybe you take a photograph which will remind you that it's not useful to invest in O and cvamp if you don't have them. So vestibulopathia aguda unilateral, pars superior utriculo, ovamp reducido, and pars inferior cvamp reducido. Marius paralyticus post-traumaticus, that can be a medical legal issue. So if you have a patient with head trauma and dizziness, you can confirm that. Then vestibulopathia bilateral, that's amazing. You have no canal function and the otolith organs are normal. That's a typical finding. We don't know why. And then the major indication is superior canal dehiscence syndrome. Good. Vision vertical subjectiva. That's nicer and more interesting and more relevant. And we described, not for the first time, this bucket test, but we systematically evaluated that. Here you can see it from the patient's point of view. Those who are the proud owners of Gafas de Miguelito, they also have an instruction on how to build the bucket test, including the scale. And for patients with an acute vestibular syndrome, this is a wonderful test because it tells you that there's something wrong within the vestibular system on one side. It does not tell you whether it's peripheral or central, but it just tells you that there is something wrong. And here you see it from the examiner's perspective. So you hold the bucket, turn it 5 times in one, 5 times in the other direction in a pseudo-randomized way. You measure the deviation, and the normal range is very tight. It's 0 plus minus 2.5 degrees. And so it's a very helpful test, and it's sensitive in acute unilateral, peripheral and central lesions. And it's important to evaluate central compensation, because normally it's compensated after 20 days. If it's still deviated after 2 or 3 months, the patient did not compensate well. So I think that's the second very relevant indication. It's part of the ocular tilt reaction. So now quickly at the end, the results of this worldwide survey on vestibular testing, which was done together with the Morani Society. So here are the centers which replied, 38 centers from all continents except Africa. We asked, what are your normative values for these plethora of examinations? And here you see a wide range of reference and cut-off values. And this is what is now in neurology under
Equipo de emergencia adulto, presentarse, planta baja, gimnasio de rehabilitación.
So for instance here the cut-off values.
Equipo de emergencia adulto, presentarse, planta baja, gimnasio de rehabilitación.
Okay, so here for bilateral vestibulopathy, depending on the lab where you go, you get the diagnosis or not. Same is true for vestibulopathia aguda unilateral, so a wide range, and this has to be unified. The same is true, but not in that bad way, for the caloric irrigation. So here's the range 20 to 40%. Bilateral vestibulopathy, there's also a wide range depending on the center where you are. For the CVAP, it's horrible. You see here this wide range from 50 to 350 microvolt. So what are the consequences? The consequences are, if you use one of these systems, that means you see a lot of patients, then you have to spend 1 or 2 weeks to generate your own normative data depending on your technician, your ethnic group, and the age of the patients. Just 2 weeks. So we have done that for the OVAM, for the CVAM, for the calorics, and also for the vHIT. This is time which is absolutely useful to spend, because then you rely on your own data. So mean plus minus 3 standard deviation, this is your normative value for your patients in your area, in your lab, for your technicians. That's the take-home message. Okay. We're a little bit behind schedule. Time for half a question. I'll speak to you later. His questions are very good and sophisticated, no doubt. We always have fine discussions during the breaks. Okay, so the next presenter. Really? Okay, then we need. I tried to make a joke. It didn't work. We need a break because we have to install the equipment here. So those who are, you're familiar with the vHIT, so we have different groups. And then I first present the vHIT here with a projection. You have your break. You present the vHIT. And then you can have a real hands-on course with the vHIT. And we have a lot of time for that. So I can also show you how to examine the vestibular and the oculomotor system in an interactive way, so that you can examine the colleague next to you and things like that. So we have plethora of time for a practical course, vHIT plus clinical bedside examination. Okay, enjoy your break, 15 minutes.